interesting.
Yeah, it's now 9:15, so may we begin, please. Welcome everybody. Joe, who do we have? From whom do we have apologies?
We've got apologies from Amanda, Lies, Lisa Nodes, and David Taylor.
Thank you. And we have Nicole with us in deputising for Lisa, don't we? Thank you. Okay. Any declarations of interest?
Christopher, just as mentioned previously, in regards to the agenda item on perinatal mental health, I'm the spotlight champion for that.
Thank you.
In relation just to community, I'm on the community work stream for the FSP when looking at contracts.
Thank you very much.
I should probably declare that I'm vaccinating for e-put.
Thank you. I don't suppose anybody's had any gifts.
Sorry, Christopher. I'm a volunteer for e-put, if that counts.
Okay, well, it's worth saying. Thank you very much. Nobody had any gifts. The minutes of the last meeting. Does anybody have any comments for accuracy?
I'm happy with them.
Thank you. Any matters arising which may not be covered appropriately in the current board? Thank you. The action log, one action. Kate?
One action and it's complete.
Thank you. All right. In that case, we go to a general update, Ed. Please.
Thank you. Obviously, it was the anniversary of the pandemic yesterday, so it's an opportunity to recognise the community spirit that we've had in West Suffolk and the terrific collaboration we've seen, not only in the NHS but across health and care and many partners to keep people safe. So I just wanted to record a debt of gratitude for everyone's efforts, including everyone sitting on the governing body here today. I think the two of the bigger issues will be captured on the agenda of the vaccination programme, and I know that Richard will talk about recovery of services, so I won't labour those points now. The only other thing to mention is the publication of the government's white paper on health and care, which has implications, obviously, for the way the NHS will be run in the future. We will see CCGs transitioning into new ICS NHS bodies, which will be commissioning bodies, probably on a county-based footprint, but we'll see we'll see what our final boundary will be, and also partnership health and care partnership committees, which will be there for joint decision making across the NHS and local government and voluntary sector. So those arrangements will become clearer, I think, in the coming months, and then we will have a year as a CCG to continue the excellent work that we've led for almost a decade now, and to work on the transition of the CCG into the new body. So very happy to take any questions on that, and obviously to talk about vaccination and recovery later in the agenda.
Thank you. Does anybody have any questions for Ed? Thank you. Okay, on to the strategy and service development section now then. Kate, the West Suffolk Alliance update.
Thank you, Christopher. I'm going to take the paper as read and just pull out a few bits. And as Ed's already trailed, a large chunk of the paper just gives you a bit more detail on the response to COVID and the vaccination programme. From a COVID response perspective, we are now, thankfully, moving into another phase where our numbers of COVID positive patients within the acute setting are dropped considerably, and we are looking more broadly at the changes we made during the incident response when it was at its peak, and understanding which of those to continue and which of those have made a material impact. And I think that the thing that was heartening was the level of engagement we had in terms of standing some of those enhanced services detailed in the paper around the integrated neighbourhood teams, improved access to diagnostics, looking at what we could do in the community versus to keep people safe in the community versus them being conveyed into hospital. A lot of what was in those pieces of work were part of the conversation we've been having as an alliance and as an out-of-hospital setting for a good 18 months. So what we did, which is what we did in the first wave of COVID, was almost a very at-speed pilot of those concepts. And I think we've got a good set of data and an evidence base now for what worked and what didn't work. So our challenge going forward is working with the teams and understanding what we would like to, or how we would like to keep some of those in place, especially the wraparound of patients within their home setting by an enhanced team, and then also consequently understanding from a funding point of view what that looks like to our commissioning model going forward. I think I'd like to sort of call out in particular the integrated neighbourhood teams, the people working in the localities who had to change the way that they were working to support this. And we've had an enormous amount of energy from those teams in terms of putting ideas forward and being the ones that then also went on to implement them. And I think that in itself gave a brilliant model blueprint going forward for transformation in terms of how we actually keep those who are delivering the services empowered and leading the change. Seems to have a significant impact on the results that we're able to achieve. Also mentioning our voluntary and community sector and our sort of wider colleagues in the third sector and our councils who supported through Home But Not Alone and initiatives which were very community focused and based around people wrapping around their neighbourhoods and understanding what's needed in terms of looking after each other. And also testing for us the model of moving staff from third sector organisations in and around our statutory services via volunteering and helping out with integrated neighbourhood. I'm not going to go into detail on the vaccination programme because I think that we're covering that in detail slightly later in the paper, but I do want to absolutely put a massive thank you on record for the incredible achievement and effort and work that's gone into the success story that we've had in terms of getting the vaccination out to our most vulnerable groups of our population. It was a social movement really in terms of it touching the majority of our staff and also our communities in terms of stepping forward and volunteering and supporting our primary care to deliver to the quantum at which they did, which is very well publicised, and we'll go into the detail a bit later. I must admit, Zora slightly put the piece around inequalities in just so that we can get a picture of you into the paper. But we've had, to complement the piece of work that we had already in place around what are we missing, looking at engaging with our communities. I don't like the term hard to reach, but those that we don't automatically get our messaging to, and our services don't access the services in the same way. And I think with the vaccination programme that was highlighted even further, and it's been much publicised. So we've done a significant amount of work at practice levels, working with our faith leaders and community teams to put on bespoke clinics and understand what the difference is in terms of what's needed to ensure that people are vaccinated and safe. But it's also, I think, in the broader sense, from an alliance perspective, given us an enormous amount of intelligence and contact and identified new leaders in these communities and in these smaller groups that we can then go on to talk about service delivery and recovery going forward. And then just lastly, we have a significant amount of things going on in the more strategic space around the future systems, which is the piece of work based around the future of the hospital building, but broader than that in terms of how we look at how we look at delivering services in West Suffolk, and that piece of work is proceeding at pace, coupled with, as Ed was alluded to, the white paper, and also where we're going to be going now in terms of vaccine recovery. And at the System Exec Group, our last System Exec Group, at the beginning of this month, that was the key theme, really. We have got, in terms of context for our partnership working going forward, we've got some significant catalysts that I think will have a very positive impact on what we're able to achieve together as partners. And I think that's it. The only other point to note is that Linda joined the System Exec Group as a lay member for the first time in March, and that's part of the broader conversations, again linked into the white paper. We'll look at the membership of that group going forward. Happy to take any questions. Stu?
Ed, thank you. Ed, thank you.
Oh, apologies, I didn't hear you ask me to speak. Thanks, Kate. I always really enjoy your alliance papers, and we note to self I must ask Maddie and Pam to do similar, as they really distill all the excellent work into one place, which is great. I'm very interested in the integrated neighbourhood teams, because we've been pursuing that for a long period of time, and it sounds like they're now starting to make a real difference and to be a kind of a pivotal part of our services, which is great. So my question is, I see the evaluation of the enhanced model will come through in June, but is there any early data to suggest impact, or anything that gives us a sense of how well they're operating?
So this is a little bit probably too detailed, but what we started prior to COVID was we pulled together a maturity matrix, which is a very jargony phrase, but it's basically a breakdown of the stages in which a integrated neighbourhood team operates in terms of its maturity, and by maturity meaning doing the kind of broader piece of risk stratification and understanding your population and working together and allocating teams around need, etc. So that kind of all breaks down, and it's underpinned as well by the something similar, if not the same, from a primary care network perspective as well. We took the primary care networks maturity matrix and kind of extrapolated it out, so it was the broader team as well. So we started that before COVID, and we're just starting to refresh that to understand where each of the teams are. They won't have done it neatly in terms of the progression, but actually I think we've leapfrogged several stages. So I'd like to, that was sort of the plan, to bring back a bit of an overview of that to possibly our next board. But the caution would be, it isn't necessarily exact science. We're also doing a piece of work in parallel, looking at the data we look at for community services, from a social care as well as the healthcare as well as the voluntary sector, so that we can, this is based around sort of flow and safety in terms of looking at what we've got where and is it having the impact. So those two things together are the way that I think we're going to be able to keep an eye on how things are maturing, the level of delivery, but also where we've got gaps, and we will have gaps. Also, just really cognizant that we've got very tired staff. I think it's very important to say that we've got staff who have now been working at a significantly enhanced level for well over a year, and so prioritising how we rest individuals as well is part of the very much part of the conversations we're having at the moment.
Thank you very much, Kate. Linda.
Thank you, Christopher. Similar question to Ed, actually, around the evaluation, and I see that's coming in June. And picking up on your point about tired staff, when I have attended locality meetings, those matrices that you talk about and the maturity of the developing INTs or the locality working really comes alive when they start talking about the difference it makes to individuals and the patients on their journeys. And it seems to really bring staff alive, because that's why they get out of bed in the morning, to deliver care and to make lives better for patients or for people accessing the services and their supporters and carers. That would be excellent perhaps to have the evaluation with a number of stories come through from the different areas, because that then makes the strategy come alive as to what difference it's actually making on the ground. So I think my question is, looking forward to the evaluations and what services we can keep going forward, but also let's have some individual stories that bring that alive rather than just strategy.
Yeah, I absolutely agree. And I also agree that we need to do that from a commissioning perspective as well. Having spoken about some services recently, just from a financial perspective, we had a member of staff who brought in the case studies as part of the conversation, and it materially tilted the room in terms of understanding. There's quite a lot that the impact that it isn't necessarily just about numbers.
Yeah, thank you.
Zora, thank you.
Thanks, Christopher. Ed, did you want to come back to something that Linda said, or have you got a separate point?
I've got a separate point, thank you.
Okay. So mine was not a question, but just a comments really, just about the health inequalities again and the vaccination programme, which I won't go into in too much detail, but it's really nice to see ePut and Suffolk Fed working together to deliver a really good programme, but also in terms of the inequalities, just to make people aware that Guildhall and Barrow worked with, or the Bury PCN worked with Gateway to bring in nearly 100 homeless people to be vaccinated recently, and it was a great success, and a really, really good story, and brilliant for people. And the other thing that I was just going to mention is that there's been a community ambition panel put together to distribute some of the NHS charity money that was raised by Sir Tom Moore, and the panel has picked out of not loads of applications, but some grassroots communities to give some money to. And a lot of them were just ordinary people just working to help their the people around them, focusing on social deprivation and, like you said, Kate, the hard to reach communities. And hopefully we'll see some good things happen with that money, and those people are being supported to help their communities. And so it was just to comment about that, really. Thank you.
That's brilliant. Thank you.
Thank you. Ed?
So my question was, because the paper in terms of the integrated neighbourhood teams talks about risk stratification and all of that good integrated care work. So my question was, I've lost sight of where we are with population health management in West Suffolk, because I know we didn't join the ICS programme because of the capability through Cerner. So I'm just interested to know, is anything moving forward on PHM as part of that kind of picture you've described?
Yes. Sorry if I missed that in the first question. I've been talking about this a lot this week, actually, because you're right. We are not part of the Optom piece of work, and I've been having that conversation with Anna Crisp this week and with Helena. And if I'm being absolutely honest, with everything that's been going on, I was playing catch up as part of those conversations. But the hospital have actually employed two new people within their public health team to refocus the population health management piece. And it's a bigger conversation that I think you and I need to have separately, Ed. But talking to Helena yesterday and how it fits in with the future systems piece and the work we'd already done with our integrated neighbourhood teams, it makes sense from a West Suffolk perspective to carry on with the programme. It needs more discussion, but with the programme and work. So I'm going to sit on the steering group with Anna. I agreed that yesterday, to make sure that we've got the join up across the three patches within the ICS, because the Optom work has been set up and designed for the East. And she was quite clear that there would need to be remodelling of the piece of work if West were to come online with it. But I think that they will complement each other, and ultimately the software that's being utilised from a West point of view is the one that we will have in the longer term, rather than a bespoke piece carried out sort of for I think it's a 12-week period, 6 to 12-week period. So there's pros and cons to it, but I feel that we've got a plan. We've got some additional investment that's come on from the hospital. I think we've got different voices in the conversation not post the pandemic, but we've had our leadership model from a primary care perspective has changed and developed, I think, during the last 12 months, and getting them to lead this piece of work with Helena makes a lot of sense for us, I think.
Thank you. It'd be really good to have a presentation at a future governing body if that was possible.
Yeah,
because
I'm sure we can.
Such a crucial piece of work.
Mm-hmm. Okay.
Thank you. Any further questions on that? Okay, well, thank you very much, Kate, for the paper and the session. We now move on now to item 8, the vaccination programme delivery. Ed, it looks like you're leading on this.
Yeah, that's right. So I think we've covered some of the key messages already, but just a huge thank you, as Kate said, to everyone's contribution here. It's been absolutely a team sport, and we've been so well supported by volunteers and the public in West Suffolk who have come forward. A few people on this call, I think, to support the sites, and it's been absolutely amazing to see. It's a tough programme which changes all the time, but the delivery and the support to the population has been first class. So nationally, half the adult population have received a first dose, and we're pretty much 2/3 in West Suffolk have received a first dose. So we're significantly ahead of the national position, which is very good. But as Zora was saying, we've also paid a lot of attention to inequalities and making sure that everyone's supported. So it's not just about the many, but also the few, if you like. And I was looking at the data around homelessness and rough sleepers yesterday, and I think we're approaching 90% of that cohort, although that cohort does change all the time, with a first dose, which is a really, really excellent progress. And I suppose the final point I just wanted to make was around the impact of the programme, and we see today that at West Suffolk Hospital they've only got 2 COVID inpatients, whereas in January they were much closer to 200. So the drop has been really significant, and that's not totally down to the vaccination programme, but I think in a large part that has been a key factor. So all very positive. As I mentioned, circumstances seem to change quite regularly, and as people will have read, there's a national or international supply issue. So during April, we'll be focusing more on second doses and only doing a small number of first doses, and then starting up in a big way in May with first doses. And we'll start to move into the under 50s age group at that time, I would anticipate. So excellent progress, still a long way to go. One of the MPs that we met recently described this, likened it to the Normandy landings in terms of the complexity of the operation, but also the sort of the purpose, sort of a liberation effort. And I think having those sorts of analogies is quite motivational at times when you're working so hard. So we're doing everything we can to liberate the people of West Suffolk. Thank you, Chair.
Thank you very much. Are there any questions which would be appropriate to the level of this discussion? Okay, thank you very much indeed. Thank you. On then, Richard, if you will, please, to the mental health transformation update.
Thank you, Chair. So hopefully colleagues have had a chance to read through the update paper in the pack in relation to our community mental health work. This doesn't set out everything that we're doing. There's huge amounts more, particularly with our mental health practitioner work that we're doing, our personality disorder and our eating disorder work. This particularly focuses this month around our perinatal hopeful expansion and our IAPT and wellbeing expansion. And just starting with our perinatal case, you'll see that perinatal mental health is what occurs during pregnancy or in the first year following the birth of the child and can affect up to 20% of women. If left untreated, as we know, it can have significant long-term impacts on women and their families. So we commissioned a service from NSFT a couple of years ago in line with the national expectation. But as you'll see in that first section 1.1, the intention is to continue to increase the target population size for the service up to 10% by 22-23. So the service we've got with NSFT comprises of psychiatrists, registered mental health nurses, social workers, psychologists, nursery nurses and admin staff, all working together to provide the service to this cohort of our local community. They're also working in partnership with our maternity services in West Suffolk FT and ESNET in the East. In terms of the current service, there's no waiting list for the service and people are seen within 3 to 4 weeks, which is great news. So really what this case is about expanding the existing workforce to meet that increased access standard that I've just talked about. So you'll see, particularly at section within table 1, the current establishment, and then under that, the phasing of the expansion, which takes us to a total cost for the West of just shy of 330,000 investment over the 2 years to expand the service. In terms of our patient and public engagement within this service, there's an operational group that operates the service and looks at changes like this, and that's got representation from service users through Maternity Voices Partnership, and service users will be part of the interview process for all the posts that are going to be recruited to within the service. So hopefully that gives you enough of a flavour in terms of the perinatal case, and I know we've been through it in other fora as well, and it's been through the system mental health board as well for approval. The financial envelope is the upper limit, just to be clear, in line with the mental health investment standard. So each year we get a prescribed amount that the National NHS England team feel we should be investing in each area of mental health. So this is in line with that, but there's some further work we're doing in NSFT and it's likely to be the upper envelope for this work. The second business case, again, is around an expansion of our existing service, the IAPT and Wellbeing Service, again ran by NSFT in partnership with a number of VCSE groups. Again, the national expectation is that there's a continued expansion in access. So at the moment, the target is 25%, which we are pretty much at, if not slightly exceeding. The expansion will take us further to 35% over the next few years. And this case is around what is needed in terms of the staffing to enable that to happen. So just again, for your benefit, this service supports a range of people across Suffolk, particularly adults and older people with common mental health problems and those with serious mental illness. In terms of another key facet of it, we developed with NSFT a long-term condition part of the service, and NSFT are working closely now with West Suffolk FT and ESNET, particularly around those services like cardiology, respiratory, cancer, musculoskeletal, where actually it makes sense to have more of an interface, joint clinics, etc., between physical and mental health, and that will look to continue and expand over the coming years. You'll see there's at the bottom of page 35, there's a little table that shows you actually how many individuals will be supported over the next few years as we get towards that national standard. You'll see within 21-22 that it's only an additional 420. And that relates to the fact that at the moment the service is overachieving against its access standard, which is great news for the local population. And that by the end of 23-24, there'll be cumulatively around 2,000 additional people seen and treated. In terms of its current performance, we've got more of an update from what's within the paper. The service is currently performing at 98% are still within the 6 weeks. The standard is 75 nationally. The recovery rate, so those individuals who go through the courses of support and are seen as having recovered from that, is at 54%, just under where the national standard is 50%. And as I said, activity is over the national requirement. So it is a relatively good, strong service that we've got in place already that we're looking to build on. So in terms of the investment amount, you'll see it in section 2.3 onwards, in terms of the breakdown of the staffing. There are 3 particular business risks, just to touch on at section 2.4. So in terms of access, I've already talked about that. Currently, the service is overachieving its access standard and is fairly confident that we'll continue to see increased access. Interestingly, one of the posts that they're looking to create is a marketing comms post within the service to actually work with other parts of the Alliance and service users to increase the exposure of what the service is, how it can support, how we can get people in. In terms of training places, we've already gone ahead at a level of risk between NSFT and ourselves with letting Health Education England know how many training places we would need if this business case was approved, because there is quite a long, lengthy lead-in time to actually get recruit and train to the necessary level to provide the service. And on recruitment, interestingly, this service has not struggled in the past with recruiting to the new roles. It is one that they've attracted people from outside of Suffolk into the service, but I'm conscious that effectively this is a national must-do, that everyone is looking to expand their eye up to wellbeing services. So clearly there's a pace we need to move at, and with NSFT, if we agree this, to start the process of recruitment. So finally, on the funding, as I've just said, you'll see that set out in the paper that, again, similar to what I just said in the perinatal paper, this is in line with our mental health investment standard amount, but it's the upper limit, and we're working through with NSFT that final amount. So I'll leave it there, Chair, and happy to take questions on either of the two cases.
Thank you very much. Any questions for Richard? So I suspect, oh, here we go. Jane.
It's more of a comment than a question. So just to add more flavour on the finance side. So Richard's outlined that much of the mental health investment standard, whilst it's a total that we need to deliver, it's also pre-prescribed within sections as well. And so what these investment cases are doing is working within those prescribed areas. But we've done an awful lot of work with NSFT about the way that we fund models. So previously in the past, we handed over the money for the full business cases and then looked about clawing that back. We've changed the model on that moving forward so that we will only pay for what's actually being delivered, so that any slippage in posts, etc., sits with the CCG. We were also doing an awful lot of work around their overhead rates. Both of those pieces of work will help deliver what Richard said, that this is the maximum funding envelope. So hopefully that provides a sort of better way forward for the CCGs.
Thank you. So I think in approving this paper, we're also approving the financial ask, aren't we? Is everybody? Andy, you've got a question before I go on.
It's a pretty basic question, really, Richard. And I think this is the wellbeing service that has, it's a really good news story, and I think you've done really well with it. I was just wondering, in terms of the intervention levels increasing by 25% by the end of March 2021, and you say you've overachieved that. Looking back, what is the context for our interventions looking back, if we went, say, five, just looking back datally? So we've got from 2021, we had 16,288. Where were we 5 years ago? Because it feels as though we were well below that, Richard, and you've increased it markedly. I'm asking you a question. I don't expect you to necessarily have it to hand, the information, but where were we going back a few years, Richard? Do you know that, or?
The service only started in 2017, late 2017, and it launched in February 18. So to be fair, the service has only been in existence for 3 years. So it's been a rapid climb in terms of the number of individuals in Suffolk supported. And I think if Ros or John were here, they'd be saying that this has been a service that's been needed for many, many years previous to when this service was started. And just to be clear, and John and Ros, our clinical leads, as many of you will know, say this all the time, that even at 25%, that's 75% of individuals who aren't being supported, who might need a service. So I think it's just, even though it's great that we're overachieving the national standard, there is still a lot of people out there, you'll know, as GPs out there, who could benefit from this kind of service model. But it's great that we are achieving the rate, but there's always more that we can do.
Okay, thanks, Richard. Thank you.
Any further questions? Are we happy then to approve that paper and its financial implications?
Thank you, Christopher. Just to whet your appetite then for next time, we'll be bringing cases around personality disorder, eating disorder, and then an update on the wider community mental health model, particularly the mental health practitioner conversation that we're bringing to PCN clinical directors next week.
Okay, thank you very much. Paul, procurement update.
Yes, thanks, Chair. I'll take the paper as read, but just pull out a couple of things, if I may. I think the summary of the current procurements that are in the paper are no great surprise. They've been there for some time. I think it's worth pointing out that obviously the procurement team, as it is, has been supporting vaccination and COVID for some time. And I think the statement quite clearly made their expectation they will come back online as part of business as usual and restoration of services. So I expect that list of procurement will rapidly increase as we start to review all of our contracts that have been put in abeyance throughout the pandemic. So I expect to see some changes there. I think I'd just like to draw your attention to 2.2, and that's some of the recent sort of national publication of a variety of documents which flow out of the long-term plan and recently the white paper. And essentially, the proposal to reform the Health and Social Care Act 2012 and the Public Contract Regulation 2015. And there are currently a number of papers that set out what the changes are likely to be, and in particular, the NHS provides a selection regime. And it is a really important point because whilst the default position will cease to be, as I understand it, you have to demonstrate why you're not procuring. It will be a reverse position to say your first instincts will be to actually think about internally with your current partners how you can provide the services, and then make an active decision to procure as opposed to the other way around. I think it's going to be quite important that we bring a paper back at some point when we understand what fundamental changes mean to us as a system. So I'll stop there. I'm happy to try and answer any questions.
Thank you. Questions? Ed?
Just a reflection, not a question. I presented to all of the trade unions in the East of England on the white paper recently, and they were very, very happy about the change in procurement rules. And in fact, they felt they could have written that section of the white paper. So it's quite interesting to see the politics around that. So it is quite a shift in their perception how things used to be.
Yeah. Thank you. Okay, there are no further questions. We receive that with gratitude. Thank you very much, Paul. On to the finance, performance and scrutiny section. And I think we're starting with performance. Okay,
Chair, do you want me to start off, just give a bit of context to the paper? I think the first point to make is that it's month 10, i.e. January, and now we've moved on in terms of the months to where we are. But I think there's some important context to this paper in terms of performance. And if I may just spend a few seconds just going through some of that. As you remember, back in December, our COVID numbers surged within our hospital sites, and I think as a system at one point we had some circa 400 COVID patients in our hospital, which essentially meant that our hospital to cease functioning in terms of routine elective activity, and essentially made an active decision to actually only make sure that the most urgent life-threatening activity carried on, and essentially. There were so many beds lost that we moved very, very quickly and worked with the private sector and enacted the national surge plan around moving to 100% of all capacity available within the private sector. that essentially meant that when you remember the phase 3 discussion we had where we were reporting, we were doing really quite well against the 1920 baseline of activity level, reaching 90 and sometimes often exceeding the amount of activity that was expected to us as a system. And as a consequence, we were starting to see some benefits around RTT, 18 weeks, diagnostics, etc. The impact of the second surge has meant really that our relative activity dropped to about 36% of baseline. Our day case dropped to about 55% of baseline, and endoscopy into diagnostic dropped back down to 55%. The slight sort of light or nugget in all of this is that we have managed to maintain some of our other diagnostics on MRI and CT scanner. So I think the consequence of all of this is within month 10 you are starting to see a deterioration in position in terms of that performance. So again, we're seeing 18 weeks sort of rising. We're seeing the 52 weeks in RTT going up. We are seeing some lengthening waiting list, and we're also seeing some moving backwards in terms of the waiting time within some of the diagnostic measures. As we move into recovery and restoration, we are currently waiting for our planning guidance to come out, and I believe they're coming out this Thursday. And I believe, as Richard will testify shortly, I think it's about a 69-page document of guidance of how we might choose to approach our recovery. Having said all of that, I think as a system, we are really well advanced in our planning. We've already looked at our activity and demand. We work with our partner organisation, SNEP and West Suffolk, as a system, and looking to work in partnership across various sites to essentially to achieve a reboot of our activity figures. That's largely dependent on funding as we move forward and understand some of that, because clearly some of this will have a cost, and I'm not sure we yet fully understand that element of it as we move forward. But I think we are generally well placed in terms of our planning, and I suspect that if we replicate our delivery around phase 3, I have every confidence that we'll be able to make some impact into where we are in terms of performance. I've recently joined, and the first meeting was yesterday, which is a regional elective reset meeting, which is starting to set out the expectations, and that's a weekly meeting, and as things move on, we'll be able to feedback some of the thinking around and the direction that we are likely to be receiving. I think the other thing to pull out is clearly, you'll note within the report that cancer started to deteriorate, particularly around West Suffolk. The main issue here is around endoscopy, and I know the trust are working really hard in finding out solution and alternative plans to deliver increased capacity of endoscopy, and that actually features very heavily in terms of our plans going forward. But clearly something we need to watch and work with our colleagues on. The other couple of things I'd sort of like to pull out from within the report is we shouldn't ignore mental health. And what we've also seen as part of an SFT, some rising in waiting list, particularly on CYP, ADHD and other services. I've recently reached out to the Trust to try and do some deep dive, and they've agreed to work with me to try and understand what we can do in the short term to try and address some of these rising waiting lists whilst we work through all the excellent work that Richard has described around mental health transformation. Because I think the waiting list and 52 weeks wait for children is in my mind, fairly unacceptable. So we're having those discussions as we speak at the moment to see what we can do in part of restoration and recovery. The other two elements that I would pull out is ESEC. You noted that ESEC has managed to maintain some of the activity and some of the measures that pre-pandemic. That's largely in part because of the additional investment we've put in, and we've recently agreed to carry in some of that, particularly through quarter one, to make sure that we continue that good work and that progress around that particular service. And finally, if you've looked at the detail, you'll notice that around the ambulance services, our conveyancing rate is reduced by about 4-5%. I think from memory, we are currently assessing whether this is in part the additional investment, the pilots we've now put into place, which appear to be having an impact in terms of conveyancing, which is a really good news story. So again, at some point, happy to feed some of that good story back when we receive sort of more of a detailed analysis of the impact of that investment. So I'm going to stop there, and I suspect some of my colleagues may wish to comment about other elements of the report, or happy to answer any questions.
Thank you, Paul. Does anybody wish to speak before Ed?
So I was just reading this earlier this morning, the press coverage in Essex around cancer admissions being at an all-time high at ESNEFT, and just wanted, maybe if you or Andrew Yeager would say a little bit about the trend in West Suffolk, if you have that data.
Certainly the data that I'm being given, they are returning back to normal levels, which is part of the concern. Andrew, I don't know whether you've got any more data than that.
Can I just ask, Ed, is that elective cancer, or is that cancer in emergency referrals?
I think it's cancer in emergency referrals.
Yeah.
Okay. So apologies that I haven't got that information at my fingertips. Happy to find that out.
Yeah. Andy, do you know anything about that at all?
No, I don't. No.
Okay, thank you.
I'll take that as an action.
Okay. Any other questions on performance for Paul? Any other comments from any of the directors?
I think we might be coming on to our bits, if that's all right, Christopher.
Yeah. Okay, sure. Okay. On we go then. Next to Director of Nursing, I think.
Thank you, Chair. The only additional point that I would want to draw to the attention of the governing body is that West Suffolk Trust did a self-assessment against an improvement tool which incorporates the findings and recommendations of the Ockenden report, and that proved very successful. It was backed up by a quality assurance visit by both the CCG and NHSI Leeds, and it proved a very positive visit, and significant improvements have been seen that are picking up both CQC findings and recommendations, as well as obviously Ockenden report recommendations. So it was a very positive quality assurance visit, and yeah, good improvements being seen. So excellent progress really by the Trust.
Thank you. Any questions? Okay. Strategy and transformation next.
Thank you, Christopher. So as Paul alluded to, planning guidance is due out imminently, 69 pages. I'm sure it will be a thrilling read for us in the next couple of days, but we'll then need to obviously start to plan and respond to that. So the key dates we're being told is initial response early May, final response early June, in terms of how we're locally across our integrated care system and our 3 alliances and clinical commissioning groups going to ensure that we're implementing the planning guidance for the next financial year. As part of that, we will be looking to refresh our existing transformation programmes and alliance plans, which Kate's covered part of today in terms of the alliance update. We literally just met before this meeting to talk around how we can make sure we're dovetailing all those pieces of work together. Just a couple of quick updates related to some of the programmes. Again, Kate's covered a lot of that within the Alliance update paper. Just on elective care, we are expecting in the planning guidance there to be quite a lot of detail in terms of what we need to cover. As we know, as Paul's described, we are some way not out of line with the rest of England, or indeed the region, in terms of the amount of activity that we need to bring back and support individuals who are on the waiting list. So I'm expecting that between Paul and I will be bringing more of a comprehensive update on that through to the executive. But we do have the initial elective recovery plan from the Trust in terms of what they feel they can do over the coming months in relation to outpatients, inpatient surgery and day case. On the mental health programme, we've already had the paper earlier on the agenda, just to flag also that we're also in the process of developing a framework to commission from the voluntary care sector, so to build on the good work we've already got going. And the first element that, since we last met, I'm pleased to say that we've been awarded funding for, is to develop our crisis cafes and safe havens. So that's something that we've wanted to do in Suffolk for a long time with the voluntary care sector. And I think with Jason within my team is now taking the lead on that. I'm really pleased that we can now really start to move at pace over the coming months to try and get some of those into place. We're literally just starting on that, so I haven't got the detail on where and all the rest, but we'll be doing that shortly. And then just on children's, I think the big piece that we're doing, and Paul's linked this through the procurement update, is the neurodevelopmental procurement, where effectively we're looking at commissioning again from the voluntary care sector around pre and post diagnosis support for those children and their families who need support. And then in cancer, I know that we talked a little bit earlier around performance, but also linked to that, we had a really good cancer board across the ICS a couple of weeks ago. And one of the areas, and Andy might want to come in, that just want to flag is the work that Caroline Angus is doing as our Head of Innovation with the Eastern Academic Health Science Network, where we're doing some quite innovative pieces across the ICS, including our cytosponge, which Andy will talk a bit more, I'm sure, about, which is developed as a non-endoscopic diagnostic test, effectively, out in the West. There's a pilot, a national pilot at West Suffolk FT. We've also got, you may have seen sort of the national press on this, the colon capsule endoscopy, a pill cam. So actually, again, endoscopy procedures are quite invasive. This is a capsule on a string that goes down into the stomach, takes the pictures as it's pulled back out. And again, we're a national pilot in our ICS, and West Suffolk is establishing this service. And then finally, we're also, if that wasn't enough, we've also got another one that we're working on, which I think has now gone out, which is the clinical decision support tool for 2-week wait referrals out into primary care. And that's now been, I understand, embedded into System 1 and EMIS. So what I've asked with our cancer team is I think we need to kind of publicise a bit more the work that's happening in that space within our 3 alliances, because there's huge amounts of great work happening with our clinical leads in primary care and secondary care around those areas. But that's really good that that's happened alongside our performance-related work with the Trust. So that's probably enough from me, Christopher, but happy to take any questions.
Thank you very much. Any questions? Okay, thank you. On we go then. Integration. Kate, is that you?
I think so. I was going to just pull out the bits and pieces on primary care.
Okay.
I think the headline slide on integration is just the headlines. It's quite a whizzy slide, but I think it doesn't necessarily add to the conversation that we've already had. So if I take us through the primary care slide, which is 75 in your pack, there isn't a huge amount of change, and there's quite a few worrying statistics on there, but all quite self-explanatory, really, given where we are and have been at the moment in terms of the pandemic, the rollout of the vaccine programme. So the pieces of work that we're doing now is understanding, as we're doing with the elective programme and every other piece of the jigsaw, where we go from here in terms of recovering some of these positions, cognizant of the different ways in which we are operating now. I'd like to propose bringing something back to, I'm building myself a list for the next board, but for the next board on LD and SMI health checks. I'll work with Richard's team on this, as well as our COO team, because I think that we are, we've got, via the vaccination programme, we've had additional focus on some of these groups of patients, and we are moving forward and we have our original plans, but I think it's probably, from a board point of view, time to have a bit of a refreshed look at what we've got on the table in terms of interventions to try and move that position forward. In terms of other headlines, I think as it dovetails with the piece around what's happening in the acutes, there's a significant journey for us to go on now in terms of returning to business as usual and encouraging our population to, which we've been doing through a variety of means, to make sure that they are accessing services. And the point that Ed made around emergency cancer presentations at ESNEFT. I don't have any of the data there, but I do know from our side we've proactively been texting and communicating out to make sure that people understand that, and it's probably worth using a public board meeting to underscore that message that the services are there, and if they have any concerns they should access them. In terms of prescribing, I think I'd really like to just use the opportunity to, and I might bring Andy in as well, Hassan, just put on record our thanks to Linda Lord, who retired a couple of weeks ago, as she was our chief pharmacist, and she made an extraordinary contribution to our medicines management approach and the quality of prescribing over many years in West Suffolk. So it would be nice to have on record our thanks to Linda. I don't know if anyone else wants to add anything to that.
Godfrey certainly has his hand up.
Thank you.
Linda.
Thank you, Christopher. I'd certainly like to add my thanks to Linda for her work over the years. I just wanted to raise a very quick point about learning disability checks. I know there are several practices, mine is one of them, that does just about all of its learning disability checks in Q4. At the end of Q3, we had done 1 out of 75. By yesterday, we had done 59 out of 75, and there's a plan to complete all of them by the end of Q4. I also know that that's the case with one of the larger practices in Newmarket. So I think we really need to look at figures at the end of Q4 if we're going to do comparisons. That's
the same. That is the same every year, isn't it? But I think we also every year have the same conversation that
I think I do say that it's just about every year. Yes.
But every year we also have the conversation that it's still not quite enough, and I think that you're right. We need to look at it after the end of Q4. But I think there's probably conversations we could be having, not just with primary care. There's a broader team that support those two patient groups as well, which should be supporting the practices, and they are supporting the practices as well. So yes, I think it's timely to bring it back.
Thanks.
Thank you. Andrew?
Just to support the comment about Linda, I've worked with her for over 20 years in medicines management, and she's been a knowledgeable and steady member of the team, and then the leader of the team, and I think she's been absolutely great. In fact, her retirement date is technically in about 2 days' time, but she's been using her stacked up annual leave the last 3 or 4 weeks. I have every confidence in Wale and going forward just over the next few weeks and months until we work out exactly how we organise medicines management teams.
Absolutely.
Thank you. Yes, I too would like to add my thanks to Linda because she's led the team very well over the entire life of the CCG to date. So we are indeed indebted to her. Any further, Kate?
Only further point I was going to make, there's a significant amount of work going on within the primary care networks, and there's quite a myriad of policies and rules that are attached to bringing forward the networks and them accessing the additional roles for within their organisations. And there's some strong progress being made on collectively, I think, on how we access that and make the most of getting some of that funding through to frontline delivery for each of the networks. It's not easy, but I think it's something that under the stewardship of Lois, our Deputy Director for Primary Care, we're beginning to make some progress on. We can bring back, probably it might be useful to bring back a bit of an overview of where that lands after year end.
Thank you.
That's it from me.
Any further on integration from anybody? In that case, finally, but not least, finance. Jane.
Yes, thank you, Chair. So included in the pack is the finance report up to the end of January. We've recently done the month 11, the February report, and it's reporting a very similar position. What you can see in the report is that we're trying to make a distinction between the ongoing costs of the CCG and those that are specific, those costs that are specifically COVID related, which were directly centrally reimbursed in the first part of the year and subject to a separate COVID top-up allocation in the second half of the year. So the report contains both the year-to-date and the full-year forecast, as well as a breakdown of the particular COVID costs, which you will see includes of the major items within West Suffolk CCG. They are the pass-through COVID costs that go on to our main providers, mainly West Suffolk Hospital for West Suffolk CCG. But leaving that to one side, by far the biggest area of COVID spend is around the hospital discharge programme. So that's the programme that's in place across health and social care around both continuing healthcare and also social care, in order that we quickly move ahead jointly on discharge and admission avoidance arrangements. And this fund provides up to 6 weeks of funding. And as Richard mentioned, and I'll go on to in a later paper, we're obviously waiting for the detail of next year's planning guidance. And one of the areas that will be really interesting to see the detail of for next year is exactly how hospital discharge programme continues or not into that new scenario. We know that there are arrangements in place for patients that fall under that programme up to the 31st of March, but we eagerly await what will happen after that point. So I think it's probably best if I just take any questions, Chair.
Thank you. Questions for Jane? Okay, right. There being no questions, we'll be very grateful then that is item 11 fully received. Thank you. Item 12, the governing body assurance framework, Amanda. Oh.
Amanda's.
Christopher, I think Amanda asked me to open this.
Yes, I think she did. You're quite right, Jeff. Thank you. Please do.
Okay, well, you've got the latest updated governing body assurance framework in front of you. It's regularly reviewed by the audit committee and clinical scrutiny, as well as the joint leadership team. And this latest update is, I think, based on beginning of March from the joint leadership team. So unless there's any questions to the directors, it's for review and approve the updated document, please.
Thank you. Is there anything particular to highlight?
The changes are all identified in section 2 to the report. I think the only thing I would say possibly is that the risk on the structure of West Suffolk Foundation Trust buildings now been dealt with. I think we've got a good level of assurance now through that work that the risk committee has done with various colleagues at the hospital and within the CCG. And I think we've stood their risk committee down now, unless we need to escalate it for any ongoing concerns, and we'll just monitor it by a group of individuals within the CCG.
Thank you. Any questions from anybody? Okay, thank you very much. Jane, then item 13, the temporary financial arrangements.
Yes, thank you, Chair. So this paper is for the governing body to do its kind of statutory functions around creating budgets for next year in the context of late planning guidance that we've already spoken about a couple of times on the agenda. Normally, we would have expected to have received our allocations for the CCG and the guidance of the around the plans that that's supposed to support back in certainly earlier in the spring. As we've said already, it's not anticipated before tomorrow, possibly Monday, that we will receive that. So what this paper does is try to bridge the gap with the lack of those, but in the context of what we do know, because there's been an awful lot of prior discussion about what's likely to be in that planning guidance and allocations for the new year. So one of the main features of that is that that we're not returning on 1st of April to our normal planning contracting processes where we would, particularly for West Suffolk, have a lot of discussions with West Suffolk Hospital and Norfolk and Suffolk Foundation Trust about the coming year. We are very likely to see a continuation of the block contract arrangements, the blocks that were centrally calculated for last year to deal with and to cut the required time on planning and monitoring that is normally spent on that. In the light of COVID, they will, what we understand is that they will be rolled forward for at least the first quarter, but almost certainly the first half of next year. So effectively what we're seeing is a kind of continuation of the central emergency planning arrangements for finance around COVID. So in anticipation of that, what I'm proposing to the committee is that we do a couple of things to reflect that continuation of the emergency planning arrangements, which were two things we put in place. We put in place the CRAC committee, the COVID approval committee, that looks at specifically around COVID, but more recently, particularly around the vaccination programme, central costs that we've got that cut across the 3 CCGs, or indeed sometimes are specific to individual CCGs. I'm suggesting we extend that committee for in line with what's likely to happen at national level, and also that we keep in place our change scheme of delegation. Most of that we continue to use the original limits, which are lower as set out in there, and only very occasionally have we used those higher limits, and that's normally in conjunction with the CRAC approval process, so giving that kind of extra layer of governance. And the CRAC committee, as it's set out in the paper, does report back through the finance committee, which again then reports back to the governing body. So in short, it's a paper really setting out a number of technical issues, but most importantly, we have to have a budget for the CCG from the 1st of April. So in the absence of any of knowing exactly what our allocations are, but with quite a lot of knowledge about what they're likely to be, I'm suggesting that we roll forward the budgets that we've got in place at the moment, so enabling us to continue our business as usual. And then from there, when the planning information comes out, we use our financial performance committee to look through the detail in order that we can work through what we need to do as a governing body and bring that back to the meeting in May, when hopefully that will line up nicely with the new planning timetable as it comes out. So sorry for a lot of quick answering through that there, but the recommendations are set out in the paper. Chair, if you could ask the committee if they're happy to approve those.
Thank you very much. Does anybody have any questions? Are we all happy to approve those?
Yes.
Thank you very much. The Better Care Fund, Jane.
Yes, thank you. And this really, again, is quite a technical paper. So the Better Care Fund has been in place for a number of years, as it says in the paper. The way that we operate across Suffolk is that we have a pooled fund called the Better Care Fund, which operates across the whole of Suffolk, so picks up elements from the 3 individual CCGs. This is the West Suffolk element, obviously, that we're bringing today. Now, there haven't been any major changes for 2021, for the current year, 2021. What has happened with the COVID responses, there's been a bit of a relaxation of the national monitoring and requirements. However, what we have done is we've worked together locally to set out what would be just basically the roll forward of the existing arrangements, and hence that's what's in the paper. Really, it's effectively a technical sign off for what's happened during the 2020-21 financial year, which has really been a continuation of the same. As I said at the Ipswich and East equivalent meeting yesterday, I do think there are an awful lot of opportunities around expansion of the Better Care Fund as we move further into our alliance working, and that's something that we will be looking at through alliance finance committees as we move forward about how we can make a better use of that. But for now, this really is just a roll forward situation that we're asking the governing body to approve.
Thank you very much. Any questions? Do we approve?
Yes.
Yep. Thank you very much.
Yeah.
Okay, now I think we can get to the end of this without a break and take the break between the parts 1 and 2. Is that all right with everybody?
Mm.
Thank you.
Yep.
Okay, so I think Jeff, it'll be you again then. The Audit Committee terms of reference.
Yes, thank you, Chair. The Audit Committee last year updated or agreed its updated terms of reference. They went off to NHS E&I. They've come back with some adjustments, and the Audit Committee considered these at its last meeting and agreed them, and it's for this governing body now to endorse those changes. they're shown in red in the paper, and I ask the committee to agree the necessary changes, please.
Looks good to me.
Okay, we're happy with that.
Thank you. Yes, thank you. Okay, so we go on then to the transition to the model constitution, please.
I'm taking that one in Amanda's absence.
Oh, right.
So,
okay, thank you.
Although might not be the most detailed. I'm going to take the paper as read. This is a move which it's just part of a national rollout of the new model constitution. It began in September 18, but it wasn't made mandatory until recently. So Colin Boakes and Amanda have worked through for all of the CCGs what that impact that has had in moving us over onto the new constitutional model. In 1.2 of the papers, it basically breaks down sort of some of the bigger changes, and it's really, I think, built into the constitution the ability to sort of be more flexible and take note of the health and social care developments, and the narrative behind that is it should support the moves behind the white paper in terms of moving forward. So the purpose of the paper is to bring it to the governing body for approval of the new constitution, the move to the new constitution, and then the follow up to that will be it going on back to NHSE for final sign off. So happy to take any questions, and I might need to take some of them away, but I think I'll have a go at answering.
Thank you.
We've had detailed feedback from some of the practices as well, which we've gone back on.
Yeah. And are those discussions closed now?
Yeah, there was one that was still open around exit interviews and HR policies, which Amanda is going to take offline and make sure they're very visible within our own CCG policies.
Okay, thank you. Fine. So the lid is on the consultation, is what I'm really asking. And
yes,
you're assuring me that it is. Okay,
yes.
Thank you. Okay, so are we then happy to accept this? Please.
Yeah.
Thank you. Fine.
Thank you.
The staff survey.
Hello, I'll be taking that for Amanda. I'm Giles Turner.
Hello, thank you.
Heads of People and Culture. I'll take the staff survey as read and just bring out some salient points from it. Firstly, the staff survey itself does what it says on the packet and asks our staff a series of questions about their work and what's going on. We're benchmarked against 43 other CCGs, and the Suffolk response rate was 64%. Some pieces that we're very pleased with is our health and wellbeing response, with 69% of the organisation feeling that we take a positive interest in health and wellbeing of our staff, which is higher than the national average of 47%. Next year, we want this to be even better, but we were one of the leaders in the country as far as our health and wellbeing is concerned. And this will continue to be one of our main factors in HR of making sure that our staff feel safe and well at work, especially with the changes that are coming ahead leading up into April. And we're going to make sure that we keep giving that support. The other area where we were a leader was we shared with team members having shared objectives we scored a 79% compared to the national average of 70%, which once again shows how, as an organisation, we are trying to work together towards a goal, and we're very proud of those results. Areas that we really feel we're going to have to work on are the hours that staff are working, and there's been a few musculoskeletal issues, but already we are looking at ways in which we can improve that. And my colleague Judith Lowe is doing a fantastic piece of work where she's trying to bring in monies to get a personal trainer to do online work and come up with a forum to help with those musculoskeletal problems. And she's already well on her way to making that a reality. And we're engaging with our OD group, which is made up of members of staff across the 3 CCGs, and our health and wellbeing group, which is also made up of members across the CCGs, of new initiatives we can bring forward and ensure that we can make changes that have come out from the staff survey. And we've also, because the staff survey gives us a wealth of information, we can really drill down into each directorate to pull out what matters to them. And we've already gone out to most directorates and had that discussion, and going into the various teams who will then feed back to us how they feel we can improve and what areas and what things we can do to do that. So it's really engaging the staff in making the changes that they feel will help. And we hope to have that completed towards the end of April. And that's a very, very brief summary of the staff survey. And I'm willing to take any questions that people have.
Questions? Richard.
Thank you, Giles. Just to add to what Giles said, more than a question. So we're taking the survey results down to directorate level, aren't we, Giles? So we're talking with our staff through our team meetings, through our directorate meetings, to get a bit more of an understanding of absolutely what it means at that level and what can we do within our own directorates to support some, particularly with some of the feedback that's being given. So I think just to give the board's assurance that we are taking it seriously within all of our teams. And I think I will ask a question. The only thing I think that's one of the things that's come out, and Giles has been helpful talking to my team on this, is that although the PICA survey is useful, it's quite generic in some of its style and some of the way it operates. Quite difficult to kind of get to the bottom of some of the things that it's flagging. And I think that's because of the way in which the survey is constructed. And it's difficult when it's a national one, I know, to tweak and change. So I don't know if it's something, Giles, that we might want to think for next year, whether or not we do want to do something more localised, particularly building on some of the specifics that have been picked up this year.
Definitely. And there is the capability to ask specific questions that we make up in the PICA survey. So what we're going to do is actually tailor some of the questions at the end to ensure that we're picking up from the findings that we found within our deep dives into directorates. So we're definitely going to be doing that. Yes.
Thank you. Kate.
Richard said the piece that I was going to say at the end, but I'll just add to that in that this is part of a broader piece from an organisational development perspective and just from a healing perspective in terms of making sure our staff in the broader teams with all of the providers and stakeholders that we work with, and they are their day-to-day colleagues, that we've also got a programmed piece of protected time for them to reflect and talk about what they need at the moment to work through together as a team and as individuals in terms of making sure they get what they need to heal, but also to understand, how and where we go forward from here, because I think what the last 12 months has taught us that we have to work in very different ways than we have done previously, and that's impacted on people in different ways. So there is a bigger and a very interesting and necessary conversation to have that feeds. The staff survey underpins that, but as Richard was saying, it's quite broad, and there is a more sophisticated element that needs to be tailored at a local team level. But we'll get an awful lot from that as well, I think, in terms of supporting staff and understanding what our staffing model looks like going forward.
Fine, thank you. Jeff.
Thank you, Chair. Just to say, I'm assuming the action plan and the work that will go on to address any shortcomings in the survey and the positive side will come back to the Remuneration Committee for consideration. Please.
100%, definitely.
Okay, thank you.
Seem to be the route. Thank you. Okay, I think we're happy to receive that. Thank you very much. Then, Jeff, on behalf of the committee chairs, minutes of the various meetings which take place behind the scenes.
Yes, we've got a number of minutes to endorse that's attached to the report. There's the Audit Committee, Clinical Scrutiny, several committees of the CRAC Committee, the Primary Care Commissioning Committee and the Collaborative. If I'm asking the committee to endorse these minutes unless the individual chairs have got anything to say. In terms of the Audit Committee, a couple of the items there have already been considered by the governing body. We had a briefing from our external auditors who are yet to be able to, or they were unable to meet with our former auditors to go through working papers to enable them to deliver an audit plan for us. We're still awaiting that, but I believe that work is going on. There's a new code of practice out on use of resources that we'll need to consider, and they will need to consider during the audit of the accounts. We had several reports from internal audit, which were reasonable assurance or substantial assurance, and we are assured that the rest of the internal audit reports will be delivered by the end of the year to ensure we get an annual audit opinion for our annual and reported accounts. Other than that, I would ask the committee to endorse both the minutes of the Audit Committee and the other committees, please. Thank you.
Thank you very much. Any comments or questions? Happy to endorse and receive. Thank you very much. The next meeting is on the 6th of May. I have not been made aware of any questions from members of the public. So at that point, we will close this part of the meeting and reconvene as part 2. Shall I suggest 10:50? Does that suit everybody? 14 minutes to